think that's where her strength lies. So, Dr. K, if you don't mind, I'm not going to go through your rather extensive CV, just for time constraints. As we have questions, we can put them in the chat box. It's going to be easier. We are pushed for time, so if you can just type your questions in the chat box, and we'll take them as we go. Most of the people in the Joburg area are scheduled for load shedding at 8 o'clock, so we're going to try to go through the slides. If Dr. K gets dropped, we'll then continue via audio, and we'll then address your questions as we go along. Bismillah, Dr. K, thank you very much.
Assalamu alaikum to everyone. I'm not going to waste any time because of the load shedding, and I'm going to get started. So remember, nowadays we use ARVs for two reasons. We use it to treat HIV, and we use it for the prevention of HIV. So when you're seeing a patient, the first thing you need to do as soon as you lay your eyes on them is to test absolutely everyone for HIV. If you do not test, you will not know. So every single person has to be tested for HIV, whether they're well, whether they're unwell, whether they're thin, whether they're fat, for whatever reason you want to educate your population as to, you need to know your HIV status. So once you've tested them, you need to put them onto ARVs. So remember, nowadays we're on a test and a treat program. So everyone who tests positive needs to start on ARVs with immediate effect. It's not like in the old days where you needed a buddy, you needed to think about it, you looked at the CD4, all of that is in the past. As you test, you need to start ARVs. And once you've started ARVs, the most important thing after that is the viral load. If you have got an undetectable viral load, means you have maximal viral suppression. And what this equates to is that you're as good as anyone who's HIV negative. You lead a completely normal life. You will not transmit HIV to any partner or any baby. And you know, this is one way of making sure that ARVs will stop the spread of HIV. So the viral load is absolutely crucial. If you can sort out that viral load and you're absolutely certain that that viral load is undetectable, don't worry about the CD4 cell count, it will sort itself out. But when you're seeing patients, you also need to let them understand that ARVs are for life. There's no stop-start treatment. Once you start, you've got to continue forever. And it's absolutely important that you never miss treatment. You got to take the treatment regularly. So adherence is so crucial if you want that viral load to be undetectable. And there's no reason nowadays for patients not to have 100% adherence, because remember, our drugs in this day and age have no side effects. You should have no side effects or toxicities. So the drugs in the past had side effects and toxicity profiles. We shouldn't have that in this day and age anymore. And also in the old days, we had tons and tons of drugs we used to give patients, like 4 in the morning and 4 in the evening. That is all in the past nowadays. Nowadays, we can give patients 1 tablet once a day and at max 2 tablets once a day. So you can see we've just come such a long way in the way we're going to be treating HIV. And there's absolutely no reason for patients not to do well. And what I say to all doctors, if you spend an extra 5 minutes with your patients and explain to them how the drugs work and how they zap the virus, you don't have to worry after that, because these patients understand how important taking their drugs are. And then you don't have to worry about treating them anymore. They look after their own well-being. So that is the treatment of HIV. And then we also these days are able to prevent people from getting HIV. And we have 2 ways we can do this. It's PEP and PrEP. They're completely different things. I am going to explain it because it's absolutely crucial that as doctors, you understand when PEP is used and when PrEP is used, and to be very confident in its use, but we'll discuss that towards the end. The way we do ARVs these days is that we give you drugs that zap the virus in its replication cycle. So I think a very important thing is to understand the HIV replication cycle, because if you understand the cycle, you'll understand where the drugs work and how they work and why we're so on such a good footing with ARVs these days. So they're just three big groups to understand, three sites to understand. The first is the reverse transcriptase. The reverse transcriptase enzyme takes the single-stranded viral RNA and makes it into a double-stranded viral DNA. So this is what the reverse transcriptase enzyme does. So if we were able to block the reverse transcriptase enzyme, this is one big place where we work. And we have the NRTIs and the NNRTIs that work on the reverse transcriptase enzyme and block the viral RNA from becoming a double-stranded viral DNA. So one big class of drugs is the reverse transcriptase inhibitors. The next big class of drugs is the integrase inhibitor. Now, it's absolutely important to understand the integrase inhibitor, because this is now the big buzzword in ARVs right now. And all our guidelines and everything moving forward has changed drastically because of the integrase inhibitor. So the integrase enzyme takes the double-stranded viral DNA and integrates it into the host genome. So if we can block this process, you can see you're going to really do great harm here. So the integrase inhibitors also very important to know. And as I get talking, you'll understand how the integrase inhibitors has changed the way we'll view ARVs going forward. And the next big class of drugs are the protease inhibitors. So the protease enzymes, I'm just going to cut it short and say it's responsible for the maturation of the virus. So if the protease inhibitors are a really potent group of drugs, don't allow for the virus to mature and be released. So three big groups again, the reverse transcriptase inhibitors, which forms the backbone of ARVs, the integrase inhibitors that has changed the way we look at ARVs these days, and the protease inhibitors, which we will be saving for third line going forward. So I'm going to explain a little bit more about the drugs here so you get a bit familiar with them. The first one that I said was the NRTIs and the NNRTIs. So the first one in the NRTIs, the one I'm going to place a lot of emphasis on is the ones in red. So I'm going to start with tenofovir. And the reason I'm going to start with tenofovir is this is what we use mainly when we're treating patients for HIV first line. And then we generally combine the tenofovir with either 3TC or FTC. 3TC and FTC are sister drugs, so whether you use 3TC or FTC doesn't really matter. So I'm going to refer to those as XTC. So one always combines the tenofovir with the XTC, and one generally uses this whenever we're starting patients on treatment. But remember, before we put patients on treatment, it's absolutely crucial to do the creatinine. And if the creatinine is abnormal, we cannot use the TDF when we're starting our patients on treatment. So if we can't use TDF, we're going to fall back on the abacavir, and we will combine the abacavir with the XTC as well. So I'm not going to mention AZT because I think AZT is going to be a drug of the past going on shortly. So the two big drugs to remember here is the combination of tenofovir with XTC and abacavir with XTC. And then we could combine those with either the NNRTI, and previously we combined it with efavirenz. But I have put efavirenz in the black, which means it's also on its way out. But I would like for doctors to please read the RPV, which is rilpivirine. And it's absolutely important to understand rilpivirine, because in private we have access to rilpivirine, and it's a pretty clean drug. So rilpivirine is a drug to remember. And then I said the integrase inhibitor. We used to have two of them, raltegravir and dolutegravir, but raltegravir is on its way out. And dolutegravir is the big buzzword right now. And when I say the big buzzword, you'll understand exactly why shortly. And then we have the protease inhibitors. So for doctors who are using Eluvia, you can see it's in black. You need to throw it out now and stop using it. And if you have to replace it, you have two choices. You can replace it with atazanavir and or darunavir. And as I get talking about the drugs, you will absolutely understand why there is no place for efavirenz in the use in ARVs these days, why we need to stop using Eluvia, and why dolutegravir has become so in vogue. So now remember, when we're seeing patients for the first time, we have three drugs that we need to be aware of: TE, TR, and TLD. I'm making the assumption that you understand what TE is, but if you do not, remember it's a tenofovir with the emtricitabine and the efavirenz. TR is the tenofovir with the emtricitabine and ropiviride, and TLD is tenofovir with lamivudine and dolutegravir. So when you're seeing your patients who have normal renal functions, this is what you're thinking about. I'm going to use TE, TR, or TLD. Now, when it comes to TE, you can see I've put a big cross there. And the reason I put a big cross is we need to stop using all the ARRs. Going forward, we need to take all our patients off it and either decide we're either going to put them onto the TR or the TLD. Now, if you're wondering why we need to take them off, you will understand shortly as to exactly why we need to take our patients off. TE has had its place. It was wonderful while we had it, and we had no other drugs, but nowadays we need to move to TR or TLD. I'm going to go to TR first. So in private, we do have access to TR, and TR has ropivirine in it, and the drug's name is Arrest. And the reason we would try and move our patients off the TE to TR is it just doesn't have the side effects that the TE has of neurological side effects. You can take it once a day. It's excellent for shift workers because it has no sleep issues and neurological side effects. It is not teratogenic. It allows you to keep options open for later on, and it has no interaction with contraception. So TR is a pretty clean drug, especially if you're trying to switch in private and you want to go from TE. You can happily, if the patient is undetectable, go to TR. It's an absolutely wonderful drug that has been in use for over 10 years now. But if you opt not to do the TR route, then do remember the other drug that we have available, which is now being rolled out majorly in our first line, is TLD. And the reason we need to understand TLD is because it is an absolutely potent drug. So when I say to you that the integrase inhibitors are the buzzword, this is what I mean: TLD, tenofovir, lamivudine, and dolutegravir. And the buzz there is dolutegravir, which is the integrase inhibitor. Now, the reason dolutegravir is so great and the TLD is so wonderful is because it causes a rapid suppression of that viral load. And I must say, recently I had a gynae who referred a patient to me at 34 weeks. Don't ask me why the patient was diagnosed at 34 weeks, and she needed to have a Caesar at 37 weeks. So because the gynae referred her with the bloods, and at 37 weeks, I repeated the bloods to see where the patient was. The viral load was undetectable. So you can see what a potent component the dolutegravir adds to dropping the viral load. So we have a rapid viral suppression. The other wonderful thing about the integrase inhibitor dolutegravir, it has a very high barrier to resistance. So resistance issues don't really feature. We don't have to worry about an initiation viral load. You can start anyone on TLD even without a viral load. You give it once a day. I prefer to give it to my patients in the morning. So it's absolutely excellent for shift workers. There are no food restrictions. And the other big buzzword with TLD is that we can use it in patients who have TB. So remember previously, we loved to use the TE because it was TB friendly, but now we have the TLD, which aside from being super potent, can be used with TB. So in patients who are on TB treatment, we can give them one TLD in the morning, and then we have to just double dose at dolutegravir. So you give them dolutegravir on its own in the evening. There are no interactions with hormonal contraception. And remember, TLD can be used for PEP. I will explain PEP in the end. So I'm going to just stop there and go to the next slide. Now, the reason we need to drop TE or a tripler in all our patients is because it has the neuropsychiatric side effects. In lots of patients, it can cause acute psychosis. Tons of patients will complain of bad dreams, of having the bed spin around them, of having drowsiness, dizziness, insomnia, fatigue, memory loss. Also, I have tons of doctors asking about liver toxicity. So the ephedrins can also be hepatotoxic. And I have to admit, in my own practice, when I worked in state, we always monitored viral load CD4s and creats. So I was quite aware that ephedrins is hepatotoxic, but I never really got to see it in real until I got into private practice. And when I got into private, the lab I used did an ALT, AST on all of my patients routinely. And this is when I started picking up in reality as to how hepatotoxic ephedrins was. So hepatotoxicity is another huge problem. And also gynecomastia in young men. Remember, men are not meant to have boobs. So gynecomastia is also a problem with ephedrins in men. And sometimes the ephedrins also gave you rashes between day 10 and day 14. So you can see why we do not like using the ephedrins. It is just not right. And if it's not right for you, it is not right for your patients. So you as a doctor wouldn't want to have all of those ephedrine side effects. And if you wouldn't want it, you wouldn't want all your patients to have it either. So the ephedrins has to move. So all your patients of a tripler and the a triplet generics have to be switched. So the two other choices we have now, like I said, is TR. But if you're opting for TR, do be aware that you need an initiation viral load, which has to be less than 100,000. Otherwise, you can't use TR. TR can never be used with TB treatment. And with ulcer drugs, it's not really a big problem. What I generally say to my patients, if you're taking your TR in the morning, then do your ulcer stuff in the evening. So TR, watch that viral load and watch for TB. Now, the other thing with TLD, I'm pretty certain everyone seems to be a little mum on the weight gain, but I'm very aware of weight gain. I've seen significant weight gain, especially in women. So I'm very partial to being aware of weight gain, especially since I'm a woman. So I bring it to my patients' notice that if I'm going to put you on TLD, do be aware that there can be a bit of weight gain. And if weight gain is a problem, then you need to bring it to my notice. Also, we need to remember that with a TLD is that in the odd patient, you can have a slight neuropsychiatric component, but do remember it's nowhere as bad as the TE. Insomnia might be a problem. So the other way of saying to patients, listen, take it in the morning as soon as you get up, aside from the fact that you'll never forget it, you won't have the insomnia component in there, but you need to just be a little careful with your diabetic patients. So the cutoff for diabetic patients who are on metformin is 1 gram daily. So patients who are on metformin and who have more than 1 gram of metformin a day, they cannot be on the dolutegravir, and you need to replace it with something else. In the old days, we felt the dolutegravir was teratogenic. We thought we shouldn't give it to patients in the first trimester while the neural tube was still forming. But we do know now that this is not true. It happened in Botswana in 4 patients, but this is the numbers are for the general population. So the teratogenicity in the first trimester is not there anymore, and you can safely give it in the first trimester. So TE out, TR, watch the viral load, watch for TB. TLD, pretty good, but just be a little careful of your diabetic patients. So now we've discussed regimen 1, and you've had 3 options in regimen 1. You know the strengths and the weaknesses of each one. I'm now going to go to regimen 2. But however, I do want to say to you that I'm going to tell you whatever I'm telling you. And towards the end, this is again going to change because we've had new trials out now, which make us think very, very differently again. So in regimen 2, the 3 options we have, and we're getting a 4th option now, which I'll discuss with you in the new trials a bit later on, is Eluvia. And remember, Eluvia is what we used to use previously, but Eluvia needs to be on its way out. We should not be using Eluvia anymore. We loved it in the old days because we could also use it in our TB patients, but you'll see why Eluvia should not be used anymore. And I should have had a big cross across there as well. Then we have atazanavir and Nova. So the Eluvia can be replaced with atazanavir, Nova, or darunavir. Now, atazanavir, Nova, and darunavir are PIs that work absolutely beautifully and can easily replace the Eluvia. And the good thing about, I'm going to start with atazanavir first, is that it's very, very cost effective. And recently they've combined the atazanavir and Nova, which was previously 150 milligrams, then 300 milligrams. And whenever we're using atazanavir, we have to combine it with the 100 milligrams of Nova as a booster. And now the atazanavir and Nova is now available as 1 tablet. So you can see how, having gone from Eluvia, where you took 2 tablets in the morning and 2 in the night, you can now have atazanavir as 1 tablet. It is absolutely convenient. It is better tolerated. It is so much easier. It has very minimal side effects in terms of body shape changes, in terms of cholesterol issues. So atazanavir can be taken once a day. It's very cost effective and convenient. So do remember, if you're needing a PI, atazanavir is an excellent drug. It's one drug once daily, but remember you need to combine it with the NRTI. So if you do not plan on using atazanavir, you have the other choice of using darunavir. And the wonderful thing about darunavir is that it really has a high genetic barrier to resistance. Also, the GIT side effects and the cholesterol side effects are minimal. And also with atazanavir, sometimes in the odd patients, they would have a coloring of the eyes. The eyes might come across as yellow, but remember, this has nothing to do with jaundice. So if you have the odd patient who is on atazanavir and complains of yellow eyes, remember this is just an increase in the hyperbilirubinemia, and it's got nothing to do with liver failure. So reassure the patient. But however, if the patient's like a news reader or a pilot or air hostess, or just a kind of person who doesn't want those yellow eyes, and you can easily move to darunavir that doesn't have that same side effect. So when you're using darunavir, remember darunavir comes in 400 milligrams. And if you are using 400 milligrams of darunavir, it has to be boosted with 100 milligrams of ritonavir. Also, sometimes you may not want to use 400 milligrams of darunavir, but you would need 800 milligrams of darunavir. And if you do need 800 milligrams of darunavir, remember you'll need 100 milligrams of ritonavir as the booster as well. So atazanavir and darunavir are two PIs that are absolutely wonderful because we can combine them with the NRTI and we take them once a day, whereas Eluvia should have had a big cross going across the Eluvia, 2 tablets in the morning, 2 tablets in the night. It is an absolutely humongous size tablet. In fact, one of my patients says it looks like a suppository, which is so true. It has tons of GIT side effects like diarrhea, nausea, vomiting, abdominal pain, bloating. All the big tummies and buffalo humps could be caused by Eluvia as well. And there's a little typing error there. It says no dyslipidemia. It was meant to say worst dyslipidemia. So all patients on Eluvia, if you're monitoring those cholesterols, would have been on statins. So please take all your patients off Eluvia, and you can either replace them with atazanavir or darunavir. But shortly, I'm going to say to you the other options available now, because we have some new trials which is making us think very differently again. So like I said, previously we had TE. Remember, TE has to be on its way out. You need to replace the TE with either TER or TLD. Now, if you fail these, you have to get to second line. But before I look into this graph extensively with you, I just would like to explain the new trials that are out now that has completely changed the way we look. So the new trial that has come out right now is the NADIA trial. And the NADIA trial has completely changed the way we look. And the NADIA trial is saying to us, we can even use TLD second line. So TLD previously was used first line, but NADIA is saying we can even do TLD second line. So I am going to explain this to you shortly. So with the NADIA trial, I would like for everyone to listen really very carefully. So what NADIA is saying to us is that all our patients who are on TE should and can be switched to TLD. And remember previously when we were switching patients in the same regimen, we needed an undetectable viral load, and NADIA has completely changed this. NADIA is saying to us that we need to take all our patients off TE, even if they have a detectable viral load, and switch them to TLD. The viral load doesn't have to be undetectable, and we don't have to do any resistance testing. So all the AAA patients need to move. All the TE patients need to move to TLD. We don't need a viral load. We do not need a resistance test. We can just switch them. That is what NADIA is telling us. Take all your patients off TE and with immediate effect, switch them to TLD. Viral load, no viral load, whatever, just switch the patients. That is regimen 1. But NADIA also has looked at regimen 2, and what NADIA and regimen 2 is saying that if we have patients on a PI, because remember I told you, if you fail regimen 1, in regimen 2, you're going to put your patient on a PI. And if your patient is on a PI in regimen 2, you can switch them to a TLD, but the viral load has to be undetectable. And if that viral load is undetectable, then we can switch to TLD with no resistance testing. So what NADIA is saying to us is that the dolutegravir is just as good in second line, but do remember, if you have a patient who's on 2 tablets in regimen 2, so the patient might be on Truvada, and atazanavir. And if you want to switch those patients to one tablet once a day, which would be the TLD, in this case, do ensure that the viral load is undetectable. You do not need any resistance testing, and you can do the switch. So one can see that Nadia has completely changed the way we look at ARVs anymore nowadays. And the reason for that is because the dolutegravir is just such a solid drug. It's just unbelievable as to how it hits the viral loads. And then just by the way, I do want to make you aware of the EARNEST trial. The EARNEST trial is pretty old, and what the EARNEST trial has taught us is that when patients fail regimen 1, so for instance, if they failed the TE and we wanted to switch them to regimen 2, we could easily recycle the Truvada with the PI, and we didn't need to do a resistance test. So just to explain it to you in terms of the drug use, so if you had a patient on Atripla before, and the patient was failing and you wanted to switch them to regimen 2, you could put them onto Truvada and atazanavir nova, and 2 tablets once a day. You didn't have to worry about whether the Truvada was fine or not fine, because we know with the PI, even if you had a failing tenofovir, it didn't matter. The PI will hold solid with it. So the EARNEST trial made life a lot easier for patients in my practice, because a lot of doctors in the old days would switch their patients to Lamzid and Eluvia. And you can imagine taking 3 tablets in the morning and 3 in the night, together with all the side effect in the pill loads, patients invariably defaulted. And the ones who didn't default, I take my hat off for. I would put them all on Truvada and atazanavir nova, which was the PI, and all of them suppressed, because now it was 2 tablets once a day. So the EARNEST trial was good, but I think we need to totally understand Nadia these days. And I am going to say it again. Regimen 1, move all your patients off TE to TLD, even if the viral load is detectable. Regimen 2, if you wish to take your patient off the PI and move them to a TLD, please ensure that that viral load is undetectable. Now, this is what Nadia is saying. Dolutegravir is super, super, super potent, and we need to move with dolutegravir, but just be a little bit aware of dolutegravir having its minimal side effects, but on the whole, a very, very, very potent drug. We can use it in regimen 1 and regimen 2. It's just going to bust the viral load and bring it down to 0. And this diagram explains exactly why we need to get our patients onto dolutegravir, because you can see how well it works. I'm going to give everyone a few minutes to take a break, and then I'm going to move on to PEP and PrEP. I have tons of doctors asking about PEP and PrEP, and lots of times I kind of get the impression that they're not too certain themselves about the difference between PEP and PrEP. So hopefully at the end of this time, you're able to understand the difference between PEP and PrEP. So I'm going to first start with PEP. PEP stands for post-exposure prophylaxis. And what I mean by post-exposure prophylaxis is someone's had an exposure, either a needle stick, a doctor, a nurse, a paramedic, or a person may complain of having a burst condom or unprotected sex, which it really is, or even rape or something to that effect, where someone has had an exposure. And what we need to understand in that kind of patient, we need to put them onto PEP. But if we want to put them onto PEP, it needs to be done within 72 hours. Otherwise, we're not sure if PEP is effective. So remember, what you need to have is rapid kits in the rooms, because you need to do a rapid test on the patient immediately. You cannot send the patient to do an ELISA in the lab to find out if they're HIV positive or negative, because if you send to the lab takes 24 hours to give you a result, and you need to have that result immediately, because PEP is what we want to give to HIV negative people who've had an exposure, and we need to give it immediately. So do keep rapid kits in your rooms. So if the patient has had an exposure, the patient is HIV negative on the rapid, then you can send off an ELISA to the lab and you can give the patient TLD. Now, TLD is 1 tablet once a day for 1 month. That is it. Not like in the old days, 3 tablets in the morning, 3 in the night. No. TLD, 1 tablet once a day for 1 month. And at the end of that month, we can retest that patient. That is PEP. Now, for patients who are asking for PEP, always remember to see if they need PrEP following on the PEP. PrEP is pre-exposure prophylaxis, and PrEP is what we give to HIV negative individuals so that they continue to remain HIV negative. Now, this is quite important to realize in patients who ask for it, in discordant couples where one partner is positive and one partner is negative, we need to be aware of PrEP. So PrEP is given to HIV negative patients to ensure that they continue to remain HIV negative, and be very, very positive in your outlook to giving patients PrEP. And if you decide to give patients PrEP, and if patients request PrEP, remember we do a rapid in the room, which means they're HIV negative, and then we need to pull extra bloods on them. You need to do an ELISA because you need 2 negative tests and a creatinine and a hepatitis B surface antigen. We need these extra bloods in order to motivate to the medical aides to allow the patients to access PrEP. And when we're giving patients PrEP, we give them the TE or Truvada, which is 1 tablet once a day for as long as the patient would like to use it. When the patient decides he's not wanting to use the PrEP anymore, either because he doesn't need to or because his partner is now undetectable, he can go off the PrEP. So PrEP you can cycle on and off. So I hope I've made very clear to you what PrEP is used for and what PEP is used for and what the tests you need to do in both. And remember, both PEP and PrEP are paid for by the medical aid. So you just need to pick up the phones and motivate for its use. I'm just going to run through a few slides to make sure that you understand how things have changed recently. So the first slide is...
Okay, can I just come in there? Just one question that's coming from Dr. Iqbal Rawat about dolutegravir and liver function. And maybe we could just address that question. There's no other questions on the chat. So we just address that as we go through the case studies.
I must admit that the main culprit with liver function tests and liver abnormalities has always been efavirenz. But having said that, in all fairness, dolutegravir can cause liver issues, but it's not a common thing. It's very, very, very rare. And as soon as I started using dolutegravir, and this was a couple of years ago, one of my patients was a young white gentleman who walked into my rooms. And as he walked into my rooms, I laid my eyes on him. And this white gentleman looked pretty yellow. And as he sat down, he said to me that he'd just been started on TLD 2 weeks ago by his GP. So dolutegravir is not a culprit for causing deranged LFTs. It is an absolute rarity. So when you have patients who are coming in with deranged LFTs, 9 out of 10 times, it'll be another cause like efavirenz, like TB. Remember the other thing that can cause deranged LFTs, and people forget about it, is the energy drinks. Always look for TB in patients who have deranged LFTs. So dolutegravir on the whole is not a big culprit in causing deranged LFTs. A lot of the times it's hepatitis, TB, infiltrative conditions in the liver, and efavirenz. Very, very, very rarely is dolutegravir the cause of deranged LFTs. So I think on the whole, you can close your eyes to thinking that dolutegravir does cause deranged LFTs. It doesn't really. It's such a rare occasion. So don't worry about dolutegravir causing a deranged LFT. Dr. Robert, I hope you've followed that one. Dr. Aesop, can I continue with the case studies?
Yes. Thank
I think we can carry on, Dr. K. I think Dr. Roberts' signal is a bit slow, but I think it's answered our question.
All right. Case number one is a patient who was on TE and then defaulted meds. So when we were seeing him, the new bloods, the CD4 was 69, which is very low.
you.
The viral load was very high and the creat was normal. So in the old days, the options you would have had was you could have restarted the TE, but in this kind of patient, one doesn't want to restart TE for a number of reasons. Firstly, because I told you TE is junk, but also because the CD4 is very low. So you had two options available to you after that. The one was to put the patient onto a PI with Truvada, because this will push up the CD4 and sort out the viral load very quickly. But nowadays, remember, things have changed because of Nadia. We can start this patient on a TLD. So you can see Nadia has really changed things. Case number two was of a patient who was on TE and is now pregnant. The CD4 is sitting at 429. The viral load is raised and the creat is normal. So the two options we had previously, the only option we would have had was to put the patient onto TE with the PI. And the reason I would have used a PI in this patient was because the patient was pregnant. And in view of the pregnancy, we didn't have time to waste. We needed to get the patient onto ARVs that was going to smash the viral load urgently. But nowadays, because of Nadia, we can happily go to the TLD as well. Case number three was of a patient who started TE and then defaulted meds. So the CD4 dropped to very low. The viral load was high, but in this patient, you can see that the creatinine was raised. And remember, in patients who have raised creatinines, if you're going to take them off the tenofovir, you always need to do a hepatitis B surface antigen. If the hepatitis B surface antigen is negative, then to move the patient onto abacavir or Demiva is not a problem at all. But if the hepatitis B surface antigen is positive, then we need to use a little bit of tenofovir in the mix for the treatment of the hepatitis. So this patient was put onto Demiva and a PI to treat the HIV, but however, we needed to add a little bit of tenofovir in the mix just so that the hepatitis B could be treated. Patient number 4 was a patient who was on TE, defaulted treatment, and then when the bloods were done, you can see the CD4 is right in the boots. The viral load is extremely high. The creat is normal. In this kind of patient, it's absolutely important to remember that in patients who have very low CD4 counts, we need to do a cryptococcal antigen. And if the cryptococcal antigen is negative, that is cool. And then we need to do a urine lam to exclude TB. A urine lam is done to exclude TB in patients with low CD4s. And this patient's urine lam came back negative. So we could safely say in this patient, the patient didn't have TB, and this patient could be started. And in view of the low CD4 on Truvada with the PI, this would have been the option we would have had previously. But nowadays we can see with the Nadia trial, we have the option of the TLD in addition. Case number 5 was of a patient who was on TE and defaulted treatment. And in all of these patients, you can understand why they defaulted TEs, because the efavirenz gave them such side effects. So this patient also came in with the CD4 right in the boots, a viral load that was high, a creat that was normal. The cryptococcal antigen in this patient was negative, but the urine lam was positive. So what this tells us is this patient has TB, And in patients who have TB, it's absolutely important to understand that we need to treat TB first. And when you're treating patients who have TB, and you need to put them onto ARVs, and you need to put them onto Perbac, remember, when you're doing the order, it's always TB treatment first. Bring in the ARVs 2 weeks or a month later on, and don't forget to also add the Perbac. So this patient was started on TB meds, and 2 weeks later, the patient was put onto TLD. And like I said, if you're going to put the patient onto TLD for the ARV, if they have TB, you need to add an extra 50 milligrams of dolutegravir at night. And then 2 weeks later, bring in the Perbac. So please don't forget, if you're treating patients with TB, you can use the TLD, but you need to supplement with an extra dose of dolutegravir that is given 12 hours apart. Case number 6 is a patient who was on TE and then was switched because of failure to Lamzid and Eluvia. And you can understand that this patient on Lamzid and Eluvia was on 3 tablets in the morning and 3 at night. And we switched the patient in private according to the earnest trial onto we recycled the Truvada and added the PI, and the viral load was absolutely undetectable. So I thought I'll just mention the earnest trial here. I'm just gonna let you also know that in our patients, do not forget to do pap smears on women. Previously, the guideline allowed to do 2 pap smears on women, one at age 40 and one at age 50. But nowadays, in our patients who have HIV, we're allowed to do 1 pap smear a year. So HIV positive women can have an annual pap smear. Do not forget to encourage circumcisions in your patients. Circumcisions can decrease their chances of getting HIV. If you're giving patients PEP, we treat PEP for 1 month. PEP, try and encourage in your patients as best as you can, especially in patients who request it and in discordant couples. And the last one that I've added is patients are people, because sometimes we kind of forget that. So always remember that treat patients like you would want to be treated. Thank you very much. I would like to thank the IMA and Hetero for allowing this teaching session to happen. Zahir, I'm not sure if there's anything else you would like to ask.
I think we just had to cover some of the questions in the chat box. Rashid Mohammed and then Dr. Bayat also has a similar question. This patient taking PrEP with Truvada then may need post-exposure prophylaxis. How do they manage? Why not just use TLD from the start? Or can you use TLD for PrEP?
Now, PrEP and PEP are 2 completely different things, and we need to understand it. So PrEP is what we're giving for pre-exposure prophylaxis. So this is to a discordant couple or to someone who's not wanting to worry about someone else's HIV status. And that is PrEP. And PrEP is Truvada. And PEP is something completely different. PEP is making sure that a patient who for that has had an exposure does not seroconvert. And that is given for a month. So we don't want to get the 2 things mixed up. And the reason we also don't want to get the 2 things mixed up, remember that you would have the odd PrEP patient as well, who might go on to seroconvert later on because maybe he defaulted his treatment and stuff like that. So it's absolutely crucial to be able to differentiate between PEP and PrEP. And what we give for PrEP is definitely not what we give for PrEP. PEP, they're 2 completely separate issues.
Okay, all right.
So PEP is given to negative people long-term. PEP is given short-term, and do not give PEP to PrEP patients.
Okay. Hope that answers your question, Rashid. He's got a follow-up on that. He's got patients on Lamzid and Eluvia with a viral suppression, is TLD then the correct choice?
Yes. What you can do is, remember, every single patient of yours needs to come off the Eluvia. You are not supposed to keep a single patient on Eluvia. So you can move to your TLD, but please make sure the viral load is undetectable before you do that switch. This is what Nadia is telling you. You can happily do that switch, but make sure the viral load is undetectable. So if the viral load is undetectable, go ahead, do the switch. But if the viral load is detectable, then do the earnest trial. Take the patient onto Truvada and atazanavir, so it's now 2 tablets once a day if the viral load is undetectable, and I can bet money that that viral load will be undetectable if you repeat the viral load after 3 months. Most times in patient default, they don't default because they really default, they default because of us.
Okay, yeah. And then Dr. Fazana wants to know any idea when the novel ARV injectables will be available in South Africa. Do you want to say something about the novel injectables?
I think they round the bend. It's just, I think it all got put on the back foot because of COVID. So it's just a matter of time, and we will have them out here. I personally think in state they will work very, very nicely. I'm not exactly too sure how it will happen in private, because remember, these are injectables that we have to give to patients every 2 months. So right now we're seeing our patients every 6 months in private. And I'm not sure how the medical aides will do the every 2 months thing, because it's quite a process. It needs a cold chain, and it's giving 2 injections in 2 bums. So in private, like I say, we'll have to figure it out. I think it'll roll out very nicely. It's just a matter of someone giving the go ahead. I think it's all ready to roll. It's just with COVID, it was on the back foot.
Okay, yeah, I suppose cost is a big issue with the funders. I suppose the earlier we engage with them, the better it is. Aisha Basa wants to know the patient who was switched to with the Hep B positive patient and was previously on TEE. You say we continue with the Truvada. It's one of the case studies. I'm not sure. I can't remember which one.
Yeah, the reason you're going to do the tenofovir in addition with an abnormal creat is not for the HIV. So remember, when we're treating our patients with HIV, if their creats are normal, we can put them onto Truvada. But if their creats are abnormal, we can't give them Truvada because the tenofovir makes renal function worse. So in that kind of patient, we give them abacavir. So abnormal creats use abacavir unless the patient has hepatitis. So if the patient has hepatitis B, we're using the tenofovir to treat hepatitis B and not to treat the HIV. So we put a little bit of tenofovir in it to treat the HIV.
So that's just for the 2 weeks. You're just giving it for the 2 weeks.
No. We will give it for as long as the patient's on ARVs, forever, but we will dose adjust. So we're not giving full doses like 300 milligrams daily, like we would do in HIV. We'll have to dose adjust whether we're doing 300 milligrams once a week or twice a week, just to cover for hepatitis. And do remember, if you are putting your patients onto abacavir, in your Caucasian patients, you need to be a little careful, because Caucasian patients can have a reaction to abacavir. So you need to just be a little aware of that, not in Black patients, but definitely Caucasian patients. So, and always be aware, because remember that our patients are aging. A lot of them are coming in with comorbidities like hypertension and diabetes. So just as important as viral load monitoring is, creat monitoring is just as important. So remember, you must monitor those creats very tightly as well, because I see a lot of abnormal creats in my patients. And if patients have abnormal creats, do not leave them on tenofovir, switch them off the tenofovir so their kidneys can recover and they on renal-friendly drugs.
That's perfect, thanks. Dr. Lesejo wants to know if a patient is on TLD, then defaults treatment, then is put on a boosted PI. Can they go back onto TLD once their viral load is suppressed?
I'm not 100% sure about the back and the forth. I just know about it going in one direction right now, where we are saying that if the PI is there and it's undetectable, we can go to TLD. But if I just think about it academically, I think it should work, because what we're saying is dolutegravir is going to hold its own and it's just as potent as the PI is. So I can't envisage a problem there. And even if we do have problems going forward, remember we do have darunavir for third line, so it'll be fine. We'll be fine.
You have an option. Okay.
Yeah.
All right. So any other questions from anybody on the panel, please post on the chat. In the meantime, perhaps just go to the next slide, please, Dr. K, so we can just show them some of the products that Hetero is setting in terms of their TLD range and that type of thing. I'm not very familiar with the drug, so maybe you can just tell us which one is the TLD there.
Yeah, now I'm going to tell you that right now. So the Luvigen is your TLD.
Okay.
So take note of the Luvigen, which is the TLD. Look at the Hetver, because if your patients have TB and you need to supplement with extra dolutegravir, then you would need that Hetver at night. So the Luvigen in the morning and the Hetver at night. And then remember, in your patients, like I say, you have renal issues, you're going to need the abacavir component. So that's your Hetorium, the one on the extreme right. Yeah, so that's it.
That's sort of a brief overview of the drugs also.
Yeah,
I just want to remember, I just want to thank you, Dr. K. We're running out of time. So we normally schedule for an hour, and I see we bang on an hour. I just want to thank you so much. This is such an interesting snapshot and a good indication of where we should go and where we should aim for in terms of managing treatments. I think Nadia trial is going to sort of change the ball game with a lot of guys' treatment, and I think the guys perhaps must contact you and follow up, and hopefully we can host you again in a couple of months' time. The webinars are quite popular, so the calendar tends to really fill up. But I'm sure we can try and fit you in sometime next year, inshallah. Just to remind everybody that our 40th convention is coming up for IMASA. If you're bored, do nothing on the 1st and the 2nd of October, join us in Durban. We've got a fantastic program. We've got a good scientific program, very strong scientific program. We've got from the Islamic bioethics side, we've got Sheikh Hassan Badna coming from the UK. We've got lots of interesting bioethics topics this year. Because it's the 40th, there's lots of reminiscing, and I think the guys want to go back to their roots, talk about why we do what we do. I think, Dr. K, you mentioned that, remember, our HIV patients are patients and treat the patient first. And I think those of you that are not familiar with the IMA, join the IMA for the webinars, come for the national conventions, come for our screenings, and come with ideas. We're open to ideas, and we really want to pick up that holistic way of treating patients, going back to the patient, the reason why we do this. Dr. K, thank you very much. We really appreciate you taking your time out, and everybody that's come out on this load shedding, challenging, technologically challenging evening. Join us. We'd like to thank Hetero also for sponsoring this and giving us an overview of some of their medication. Any other questions you can post on the chat group? Otherwise, I think we close the meeting.
Dr. Esop one now saying, if the doctors are stuck and they need a hand with anything, they're more than welcome to send me a WhatsApp, and I hopefully will be able to respond to the WhatsApp.
Okay, excellent. And I mean, Dr. K, they can, if they're looking for you, they can find you at Garden City. Or how else can they just Google you? Or I suppose they can Google you.
My WhatsApp number is, you can make my WhatsApp number available. I have no problem with that.
All right. If anybody, I think what's your number? I think the easiest way is to contact you on the groups. We've got your groups. I think it's going to be better that way, because this thing will go into a YouTube recording. So let's try not get you spammed. It's another challenge besides ESCOM. Any other comments from? Well, as you can see, there is a lot of thanks, and they found the talk very interesting. Anybody coming up with any ideas for future webinars? As you know, our branding seems to be sticking now. Please, everybody knows Sister Kashifa. Sister Kashifa with any thoughts. But I think we close the meeting now. Thank you very much, everybody. We'll close with العصر. أعوذ بالله من الشيطان الرجيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر.